Welcome to Discover Midwives, the podcast where we explore the art, science, and impact of midwifery. I'm Jessica Brumley, and each episode we'll uncover the stories, the history, and the expertise of midwives. This is your space to learn, connect, and celebrate the power of midwifery. Let's discover midwives together. Welcome to Discover Midwives. Today, we're talking about something many people don't realize. Midwives don't just care for people during pregnancy and birth. They care for healthy newborns too. And this is actually a core part of our education and training. Joining me today, I'm just so excited to welcome Michelle Palmer. Michelle has practiced full scope midwifery since 1998. She's a passionate advocate for physiologic birth and really is a leader locally, nationally, and globally. She has been a great friend in this journey of midwifery leadership, and I'm just really thrilled to have her here today. She completed a PhD in 2023 with a research focus on the normal newborn. And in addition to her clinical work, she's currently the specialty director at Yale School of Nursing for midwifery and the women's health nurse practitioner programs. Welcome, Michelle.
Thank you.
So I'm curious, what first inspired you in your focus on the care of newborns as a midwife?
It's interesting because I actually started out with a degree in art history and had the opportunity to travel to Peru. And during that trip, there was a beautiful, 9-month-old. And it was fascinating to me, the differences in how this parent-child interaction was happening. And during that trip, the friend who I was with, another Michelle, found out that she was pregnant and chose to have her baby at home the following February, which was not a very common choice in Rhode Island in 1990. And I was invited to the birth. And I was just, I could not get enough, when that birth happened, it was a very difficult birth. She actually had a fraught history of trauma. And at one point, the midwives who were attending her considered transfer. And then she turned around at the car door and said, "Nope, I'm doing this," and turned back around and had a over 9-pound baby boy. And I was just in love with the whole process. And I think for me, it struck me how these three women cared for this one woman and just surrounded her with such support and grounding and also cared for the newborn in those early days and really held the dyad, and I think so that was my first foray into all of this. And then I went to Frontier, and Ruth Wilf was our person who was like, you realize that the person you're caring for is going to be a parent the rest of their life. Like labor is just one day. And so really instilled. And at the time that I became a midwife in 98, we could continue to care for newborns, beyond the 28 days that we're now, our scope of practice is today. And so and my first 30 births were with the Amish in Lancaster. So again, I had a lot of immersion with the importance of dyad care beyond, just the immediate birth time. And so understanding what a well baby looked like at the time of birth, but then also what a well baby looked like at 24 hours, at 48 hours, at 1 week. At 2 weeks, at their 6-week visit, when they would come and you would see, that they had made it through the trials and tribulations of those early days of breastfeeding and see the cohesion of, that parent-infant bond. And it was pretty magical. I've been accused of being addicted to the purity of the moment, and I would say that's very true to this day.
Oh, I love that. Thank you for sharing that story. So you talked about the sort of course of care of the dyad, the mom and the baby together. And so right in the beginning, in the first few minutes when a baby is born, what are the priorities at that time?
It's really about our perception. This was actually something I studied intensely during my PhD, and what we see, what we hear, what we feel, what we smell, and how that baby feels as they're emerging. Do they have tone? What is their color like? Uh, are they making squinchy faces as they're crowning? Are they already making an attempt, or are they a little stunned? And are we anticipating that we're going to need to do a little additional support? Um, and then, you know, usually we'll bring that child right up to, the mother's chest and be assessing, further, are they adjusting? Because they're designed to be there. They're not designed to be taken away from their parent. And, bright lights and loud people's voices and other strangers touching them and colonizing their microbiome. They're designed to be with the people who made them. And so that's something I I had great mentorship in being supported to own that assessment, and why, if I were to intervene, why was I intervening? Did that baby just need to be kept warm? Did that baby just need a little reminder of that they were on the planet now? Um, but how could I do this in the least disturbing way so that what they were wired for could unfold the way that it was supposed to?
And and that whole first hour, so a lot of people will call it the golden hour, right? You'll
Mhm.
see that talked about. Um, what makes that first hour so important and so special?
It's really about the unfolding of that family. It's really about, if you have an undisturbed birth, that baby will just kind of like open up like a flower. They'll open their eyes. They will do the breast crawl, to feed. They will, be exploring. They're right when they're skin to skin. They're listening to that heartbeat that they're so familiar with, and they regulate. They regulate their temperature, their heart rate, their respiratory rate, based on their environment. And so it's so important to create an environment that's welcoming, create an environment that is something where they can feel safe and not startled. There's some research really around the vagus nerve, and um, how that sets our future psychological well-being.
Mm.
Uh, and that, yes, some of it happens in utero, but some of it happens right at the time of birth, and the impact of that. And so how can we best support that process, as opposed to intervening in a way that's not necessarily evidence-based in what a newborn needs.
I remember one time talking to a newly, expected parent about this, this transition, the skin to skin, the birth crawl, and she said, "Oh, so." She compared it to like pups. So I said, the baby will like self-attach. And she goes, "You mean like pups?" And I said, "Yeah, exactly like that. We're
Yeah,
mammals. This is
yeah,
how we were.
exactly.
This is how
This
we
is
were
how we're
designed."
designed. Exactly. Exactly.
uh, um, so, um, uh, so I think that to many of our listeners, they would be surprised to learn that newborn care is actually a core competency for certified nurse midwives and certified midwives. Um, can you tell us what that means? Like, what are midwives trained to do for a healthy newborn during the first 28 days of life?
Yeah, so midwives are trained to understand, what a well newborn looks like, and to, just like they would with pregnancy, consult, collaborate, or refer based on the needs of that newborn. So if something like jaundice develops, if something like any signs of infection develop or anything like that, we're going to consult, collaborate, or refer based on the needs of that baby. One of the common, today, since the development of the lactation consultant and different lactation counselors, is that people don't realize that midwives, actually part of our core competencies is all around breastfeeding and chest feeding, and how to make sure that a newborn is thriving, that there are no signs of dehydration or hypoglycemia, low blood sugar, that what the difference is for expectations around what that baby's taking in, and what their output is, and our assessment of that. And then anticipatory guidance around, those first things like vitamin K and metabolic screening, if someone's choosing to do that with their baby, and the evidence behind why we do that, and doing congenital heart disease testing, with the pulse oximetry in the first 24 hours, and doing hearing screens. So like when I had my home birth practice, we did all that. And people were just like, oh, I don't have to have visiting nurse come, or I don't need to go to the hospital for that. It's like, nope, we have all this equipment. We know, how to interpret these tests. We know if, there's something where, we did actually have a baby who needed to be referred for further hearing testing at one point. And I did have with my colleague an instance where we had a baby who unexpectedly had Downs and had a heart situation that we needed to transfer, but we were able to consult and actually keep that family at home for the first 24 hours, because we weren't anticipating. They were evaluated, but then they were able to come back home. This baby had what's called a VSD, ventricular septal defect, and did eventually need additional support, but it wasn't something that needed to be done immediately. So a lot of cross collaboration that people don't think of. People often think of midwives consulting with obstetricians or maternal fetal medicine people for around pregnancy, but they don't often think of how we collaborate also with family practice or with pediatric providers to for the newborn when we're doing that care. And it was lovely for our clients in the home, because they could actually stay home for the first 2 weeks without having to bundle that baby up in the weather, or disturb their baby moon and that energy in their own space to have to bring that baby in, because we were coming to them to do that care of weighing the baby, of making sure that their color was okay, of answering questions that everybody has in those first days of, is this normal? Is this, these noises they're making, or if they were having a little bit of spitting up, kind of things, or just any of those early days questions that come forward as skin changes that happen, normal newborn rash stuff, or the cradle cap, or any of those kinds of things, and just kind of talking through what things they can do in their home, and then always being open to, if they were feeling that they were still uncomfortable, it's like, we can always make arrangements for you to be seen. That's this is something I really enjoyed in that practice, is that we had both obstetric and newborn privileges at the hospital where we would transfer to if needed. And so we did bidirectional transfer. If we needed to go in and somebody needed an additional assessment for reassurance or what have you, we could do that with our colleagues there. And if all checked out fine, they were like, great, you're good to go back to the midwives. And we would just continue on our merry way, continue, with their care.
Wow, that sounds like a dream. It's nice to know it
Yeah.
exists some places. I mean, so I would say what you're describing is certainly not the norm in most places where birth is happening in the United States currently, which is in hospitals. And in more urban and suburban areas. And so I think you've touched a little bit on the places where someone is more likely to see this happening. You described your home birth practice. You described working in a rural community with the Amish midwives. Can you just talk a little bit about, what settings where midwives are likely to be
Yeah.
providing the newborn care?
Yeah, I mean, I really brought some of this model back from the time that I worked in New Zealand, actually,
Mm.
because midwives there continue to care for the newborn and do weekly visits for 6 weeks. But here, one of the places that I worked was a federally qualified health center. And again, wraparound care in that way. And then in the other practices, because I've worked in tertiary care centers and, places that do 10,000 births a year. And even when I worked there, it was interesting because that was my first years as a midwife. And maybe a baby would need to be transferred into the neonatal intensive care, and I would go visit, and the staff there would be like, "Oh, this is not as common." So really, it does take you having the initiative. It's not, there is. I think many of us, especially if we're in a very busy practice, a high volume practice, where we hand that baby off to the colleagues that we trust to do their role of pediatric care, and sometimes don't have the time or are supported in being able to do that continuity piece. But for me, it just was always really important to be able to touch back with that family and continue to show my investment in that continuity. So I think it does, yeah, that is a little bit of an extra step in practices where that's not the norm. And then I also worked in community birth hospitals where you had that continuity where you're everybody's together, and you are seeing that parent and child the next day in your postpartum rounds, and you're working with them on their what this baby can do in their reflexes, in their just doing a physical in front of them to
Mhm.
to actually reassure them, give them information and confidence around, oh, look at how well this baby, or witness them feeding, and really expand on, look at how well this baby is, tuning into you and is showing they're ready to eat, and you're responding in such a positive way. So really reinforcing, and that's like a 5 minute interaction. That's not, you're not spending necessarily a half hour in that room, especially if you have 8 people to round on, but just those small pieces of reassurance and continued investment into the growth and development of that family. It doesn't take much for us to do, and it is a natural extension of the care we've been giving over the 10 months that we've gotten to know this person, and maybe and the rest of their support people. And you know it's fascinating to me how people will share so much more with you with just those small kindnesses, those small, taking a moment just to recognize and to call out something you're noticing in their interactions with their child, or how what is happening with their newborn, to give them another tool in their toolbox to go home with, right?
I think you bring up an excellent point because even in places where the midwife is not the primary newborn provider, they do have many touch points likely, right, in the postpartum period with that new family.
Mhm.
And I think it's important for people to know that your midwife can help answer questions about your newborn. And your pediatric provider is likely to have knowledge that could help to support you as a new mom as well, right? And so it's not these like exclusive silos that
Exactly.
exist, right? Your pediatric provider is probably screening you for depression, and your midwife is probably right,
Also,
evaluating how you're bonding or how you're feeding or how's the baby sleeping and having conversations with you about that. And so there's so many places where support and nurturing can occur. It's not necessarily unique to any one place. Yeah.
and it's we talk about it sometimes as like another set of eyes, right? Another
Hmm.
set of ears to listen to you with. And then, the hope in when you're able to cultivate this, in your practice of collaboration, so that if you do see something you can, do the referral right there back to the pediatric provider, or you can, say, hey, I'm going to reach out to your, lactation person that you've been working with and just have a conversation about, what we saw today with, hearing the milk transfer, actually listening to how, the latch is going or what struggles you're having, or, if I gave a prescription for, cream to help for trauma for, feeding and things like that. So it really is, again, that cross collaboration that makes all of our care um, so much more impactful
Hmm.
than us operating, as in a silo or on our own. And just like, and also modeling that for the person who's coming to see you, maybe is a first time parent and isn't used to asking for help, or maybe is an older, mom who isn't used to, this teamwork piece,
Hmm.
has had to do so much on their own. Um, so I think it's also a little bit of modeling that, you don't have to have all the answers. I don't have all the answers. I'm going to reach out when I need additional support, just like I'm hoping you will as well, right?
Yeah, we need that whole community, right? New parents do worry about so much. Uh, in your experience, what are some things that new parents worry about that actually are completely normal?
Breathing patterns,
Mm.
feeding patterns, when the baby changes in how their stool is, so that usually there's a big shift at the 6 week, between 4 and 6 week visit of how they're not pooping every time after they feed anymore. And is that okay? And is it that I don't have enough? Is it that they're not constipated? Just the things that we think of for ourselves that are different for a newborn, or even in those first few days, how fussy a newborn can be, and talking about how, well, think about it, they have never had any gas that they've had to deal with, and so they're like, what the heck is this? And I always, liken, what, because many babies will get a little bit of normal, like physiologic jaundice, not,
Hmm.
you know, less babies will get jaundice that will need intervention or anything additional. But they'll a lot of the time have almost like a diarrhea belly as that bilirubin is breaking down and being passed through their system. So just having a conversation around that, and how important it is for that frequent feeding when they are a little bit yellow, because it's actually, the peeing, the urine that helps them excrete the bilirubin more quickly. And also just talking to parents about how quickly babies metabolize breast milk, human milk, and how, like, if they are in need of any things that are happening, they can actually feed, like, even if a parent is, like, say, planning a circumcision, or they need a procedure, the baby needs a procedure of some kind, they can feed them usually, up to 45 minutes before, unlike formula that they would need to wait. And then a lot of families will have different plans for feeding, and um, again, supporting them in what works for them. Maybe they're planning on going back to work right away, and they're not thinking that they can do they're thinking that they can only do one or the other, right? But talking to them about, no, if it works for you, to have that cuddle time when you get home, it is totally fine to do supplementation during the day, and then, feeding when you get together at nighttime, if that works for you. And, one of the things I used to always say to new parents was, you know, one day is better than, like 2 days are better than one. And from there, you kind of figure it out together. It's not, this is just like how you chose to do your labor. We're here to support you 150%, whatever that needs to look like for you and your family. And if it's not feeling comfortable or right, then we will find what does feel right for how you want to nourish your baby. And so that's a lot of the times people will think, oh, I can't go to a midwife because they're not going to support me if I'm not, feeding a certain way or making certain choices. And, you've talked about this a lot on your podcast, but we support all different kinds of families and all different kinds of choices around what those families choose to do with, and that includes how they choose to parent, and what that can look like. Our job is to give them the information to make an informed decision around the choices they're making. Um,
Love it. Perfect. Exclamation mark.
yeah. Or in
Okay.
delivery.
So these are, so we just talked about like what's normal, and people worry about, but what are the things we really should be worrying about? Like, what are the warning signs that parents should never ignore?
The things I talk to people most often about is if your baby is not feeding. Babies are really resilient little creatures, and they will look well, look well, look well until they're really not. And it can happen very quickly. And so I always talk to people about making sure that the baby is being kept in a good stable temperature environment. So in the summertime, it's really easy to, you're feeling warm, so you want to throw your air conditioning on, but a baby usually will need at least one more layer of, clothing than we have on. When they go outside, they should have a hat on. They shouldn't have their little soft spots exposed to, the elements and all the stimulations. We talk about that. But if a baby doesn't feed, that to me is always a very early sign that something's up, something's not okay. And in early days, that can look really different, because, like right after birth, they may take a big, 4 or 5 hour stretch. But then after that, they should be up every hour and a half, every 2 hours, sometimes even more frequently, because of how quickly that human milk is metabolized, but also because they need that to keep their glucose stable, to keep their blood sugar stable. And so, and also to keep their output so they don't, because in the beginning, we do expect that they're going to lose a little bit of weight. They have a little bit of extra water on board when they arrive a lot of the time. And some babies are going to have more room, or what we call the brown fat for that, those nice little chunky babies. But other babies aren't going to have as much reserve. And so it's really important to look at, like their lips and make sure that they're not getting any signs of dehydration, or that their little soft spot isn't sunken in, their fontanelles, or that again their color is looking normal. So if all of a sudden your baby's looking like a little glowworm, that is definitely a reason why you need to be seen again, and maybe get their bilirubin checked and make sure that they don't need support with Billy lights or anything additional. And that's like something pretty simple, like a heel check, a heel prick, where you can get both the blood sugar and bilirubin assessed for. Um, and yeah, but I'd say the most important thing is that, most babies are going to have good tone, where they, kind of cling to you. They're not little floppy rag dolls. And they're going to, usually root around, even when they're not super hungry. That's usually just a natural reflex for them. That's just showing that they're engaged, and they're already showing their little personalities from the get-go, of sometimes they're little talkers, sometimes they will, the communication is a lot of the time a cry, but like a cry for um, hunger is usually a late cue. Usually they're going to show you other signs where they're like bringing their hands to their mouth, or turning their head and looking around for you to bring them to the breast, or to feed with bottle.
Love it. I'm never gonna unsee a glowworm. That's that is ingrained in my head now as a jaundice baby. Okay, babies should be eating well and regularly. They should be peeing, they
Yeah.
should be like reaching out to you, clinging to you, right? Not be limp. And I guess, fever would be another thing
Yeah,
not to
either
ignore.
feeling
Yeah.
cold to touch or
Mhm.
feeling warm would not be
Mhm.
an okay thing, because a lot of people don't realize newborns a low temperature can be
Mhm.
something that is as dangerous, if not more so, than a fever. They don't always have the energy to mount a fever.
Yep.
And just like with an elder, when a temperature gets low, that is never okay. In the beginning, we're only expecting, like those first 24 hours, we're just expecting one wet diaper and one stooled diaper. And it continues on the second day, 2 wet diapers and at least a stool, 3 wet diapers and at least a couple stools. because that stool is telling you that they're not losing weight, right? When we have that gap in when we're seeing them having a poop, that is a sign that maybe they're not getting as much as they could get a little bit more. But by the time they reach a week, they should be having 6 to 8 wet diapers and at least a stool or two a day. A lot of babies will start to have transition from the, kind of that goose poop, thick, sticky, dark, that was the first stool, to more transitioning to kind of a greenish, and then to the yellow that people are more familiar with, like that kind of looks like cottage cheese
Yeah,
or milk
yeah.
curd, right?
That stained every shirt that I
That
owned for the
stained
first month
everything.
of each of my baby's life.
Yeah, yeah.
So yellow. Oh my gosh. Well, feeding, you've mentioned it a lot, and it is really, I think, one of the biggest concerns for new parents, right? Am I making enough? Is my baby getting enough? It's like primal.
Yeah.
What does support from a midwife look like regarding feeding in the
I
early days?
I think that, a lot of the time we can assess how someone is actually, if they're nursing, if putting the baby and they're receiving human milk, then we're going to assess like milk transfer. We're going to assess, are we seeing that things are comfortable? Making sure that if a latch is gone awry and when the baby comes off, it looks like more like a lipstick, then we're going to talk about, that there may be needs to be bring that baby in closer. A lot of the time, with a second or third time parent who maybe has done this before, they'll be used to just that baby reaching out to them and latching on their own, whereas a brand new babe isn't going to do that as well, and they won't get that deep latch, which is going to help them actually get better milk transfer. And so we do an assessment around that a lot of the time. We'll also be asking them, just like their pediatric provider, about output. And we're going to make sure they're comfortable. And if they're bottle feeding, we're going to talk to them about paced feeding. We're going to talk to them about the baby doesn't need to finish the whole bottle, because that sometimes can actually cause them to be up at night with gassiness and a stomach ache, and it actually bypasses their feeling full. And we don't want to do that, because that's part of how we know we've impacted our weight gain, in this generation, is that we had this, everybody should finish what's on their plate or finish everything that's in the bottle. And that bypasses our usual regulatory, how we're satiated, how we know that we're full. And when we do that, then it kind of becomes a bit of a cycle, right? Because babies suckle for comfort and not just to be fed, not just for nourishment. So really working with parents around anticipatory guidance on cues, on if a baby is really just overtired, if the baby has just been overstimulated because you had a bunch of family or friends over, and everybody was talking and maybe holding the baby, and they're out of sorts. Or one of the ones that was classic for me when I lived in New Zealand is I worked in a remote rural area of only 500 people, and you had to drive an hour for groceries. And the first time that a family would take their baby to get groceries, they would be a mess the next day. So the parent would call
Mm.
and they'd be like, "What is going on?" Like, they're so fussy. And I'm like, they were in that car seat for over an hour, two ways. And yeah, they're just a little bit, they got a little bit uncomfortable
Hmm.
with that. And it was, most of the time that was what was going on. And how we would leave it is that if it doesn't resolve, and like another couple hours kind of thing, call me back and we'll talk through, and maybe I need to come and see you, and that kind of thing. But a lot of time they'd be like, "Oh my gosh," in New Zealand, they call gas wind. They're like, "Oh, it finally released all the wind and they're so much better." And I was like, "Yep." So we talk about maybe a little bit of infant massage, or how you can do the bicycle legs to help babies release
Yes.
their wind. Yeah,
Oh my gosh, so
super
cute.
fun. Yeah.
uh okay. So fun segment. I'm gonna read a statement and
Okay.
you're gonna tell me whether it's a myth or a fact.
Okay.
Okay. Babies should sleep through the night after a few weeks.
That is a total myth. So
I don't
sorry.
think I don't think my baby slept through the night for the whole first year.
Usually what I find is babies who get above 10 pounds will sleep a longer stretch, but still not completely through the night. But usually that will give them that, I don't know, for whatever reason, that seemed to be kind of a magic number where they got a little more stretched out and got used to everything, moving in their body and
Yeah.
at least give you 4 hours.
I
So
was gonna say 4 hours is sleeping
yeah,
through the night in my brain,
right.
right? Yes, yes. Okay. Spitting up always means something's wrong.
No myth. Yeah.
Mhm.
Babies spit up all the time. Sometimes they overfed, sometimes they're just getting used to all their little sphincters aren't, fully formed yet. And so sometimes if they just if we lift them up too quick, if we do, or they're trying to actually relieve themselves with either a toot or to have a stool, they'll end up spitting up because it pushes up on their belly. They just don't have enough room.
It's also tiny.
Yeah,
Okay, you can spoil a newborn by responding too quickly.
total myth. Babies
Only fruit spoils,
cannot.
right? Babies don't spoil.
Exactly. Babies do not spoil. And the more love we show them, I mean, we absolutely know that babies who are not touched and who are, left unattended do not thrive. We have seen that time again in so many environments. So no, you cannot. And this is time that you will not get back. So it
Mm.
is worth soaking up every drop.
Every baby loses some weight after birth.
That is true.
Mhm.
Most babies. It was extremely rare. I would say the times I can count maybe on one hand the parents that I've attended that their babies haven't lost weight, and many of those were still feeding like an 18-month-old kind of thing. So they weren't waiting for that colostrum to change over to their full milk. But that's pretty unusual for a baby not to lose any weight.
Yeah. Parents should trust their instincts if something doesn't seem right.
100% true.
Mhm. Yeah.
Just like, and we should listen to you as providers. So don't, if you're not getting the support that you feel is needed in this instance, you call upon another person. It's super, and that was the other thing I wanted to say about the spoiling part. If you need a break, it is 100% okay to
Mm.
call in support so that you can take a shower or take a nap or just go out on the back step and have a cup of tea, just have a moment of solitude. That is extremely healthy as well. You're not supposed to be the sole individual for this little being 24, 7 days a week. Like we were designed to support each other and not just one-on-one.
I think that's for me, I think that would be the one thing that I would want new parents to know.
Yeah.
Right? Yeah, it's this idea, the idea of us being independent and self-sufficient as families, as new parents is a fallacy, right? We need to call in the help for sure.
Yeah,
What
and
do you,
I mean, it's spread the joy. I mean,
mm,
someone's doing so much joy. Like, it's okay to share that, and it's okay also to share the challenges
mhm.
and have that burden get lightened a little bit by having someone just come and say, "Yeah, I hear you. I'm with you. I get it." Yeah.
I love that. What do you wish more people understood about the role of midwives in caring for newborns and families?
That the relationship you've built over 10 months can be extended. That it it doesn't mean, that the birthday is the end of your time of sharing and of being heard and of being supported by the midwives that you have developed relationship with.
I love it. Thank you so much. As we wrap up, I want to leave you with this. You deserve care that listens to you, respects you, and includes you in every decision about your body. If something in today's episode resonated with you, I encourage you to write it down, talk about it with someone you trust, or bring it with you to your next healthcare visit. Information is powerful, but using it is where change begins. If you found this episode helpful, you can follow or subscribe wherever you listen to podcasts. Sharing this episode helps more people learn about their options and what respectful maternity care can look like. Thank you for spending this time with me. Take good care of yourself, and I'll meet you back here next time. Discover Midwives was brought to you by the American College of Nurse Midwives. To find a midwife in your community, go to midwife.org.